He's Professor of Anesthesia and Surgery at the University of Illinois College of Medicine, Chicago, and the Pain Medicine Director at Advocate Illinois Medical Center. He's going to talk to us today about diagnostic imaging in craniofacial pain. Thank you.
Thank you, sir. Good morning and welcome, everybody. There we go. Diagnostic imaging in craniofacial pain syndromes. For the next 22 minutes, I'm going to dive into a fairly high-level discussion, if you will, about the modalities that are available to us in rendering a diagnosis for individual patients who have craniofacial syndromes. Starting with some of the more common syndromes, including things like trigeminal neuralgia, which has an incidence of somewhere between 5 and 20 per 100,000, or maybe 1 in 5,000 individuals. And I'll talk about other cranial nerves as well. So cranial nerves 5, 7, 8, and 9 primarily, where there's the possibility for neurovascular compromise, are known to exert and to influence painful conditions of the head and face. And then we'll talk a little bit about things like occipital neuralgia if time permits. So let's start with trigeminal neuralgia, because the literature is replete with articles and studies which emphasize the diagnostic imaging for this condition. Neuroimaging, primarily the use of magnetic resonance imaging, is critically important for rendering a diagnosis of trigeminal neuralgia, after, of course, doing your due diligence and identifying clinically what the symptomatology is and related to V1, V2, or V3, or a combination thereof. And we need this MRI to determine whether the condition is primary or secondary. Primary trigeminal neuralgia, is that due to neurovascular compromise? Secondary is due to things like tumors, for example, or multiple sclerosis. So the use of MRI imaging is eminently beneficial to us to try to make a determination as to whether we have a primary or secondary type of trigeminal neuralgia. And we use a combination of things like T2 weighted imaging, T1 weighted imaging. Sometimes we use gadolinium, although that's not essential for rendering the diagnosis. And we look for vascular contact as well as for the degree of root compression. Classical trigeminal neuralgia, or primary trigeminal neuralgia, MRI, once again, is the best diagnostic tool available to us. And I would defer to some of the people in this room, for example, Dr. Naruz, who's got tremendous experience using ultrasound guidance for head and neck painful conditions, primarily for the therapeutic options available to us. But for diagnosis, MRI remains the gold standard. Now we have available to us multiple different technologies, Tesla 1.5 magnets or 3.0. 3.0 seems to be best for delineating neurovascular compression, and the use of lower grades of resolution. 1.5 Tesla appears to be very useful for things like MS or for identifying tumors, for example. Here's an image, an MRI image of neurovascular compromise or contact with morphological changes in the left trigeminal nerve in a patient with classical primary left-sided TGN. Interestingly, here we're looking at compression by the left anterior inferior cerebellar artery. That's not the primary artery involved, and we'll talk about that in just a moment, but the AICA is often implicated nevertheless, as seen by the brown arrow over here, and then the yellow arrow identifies the trigeminal nerve. Now, there's another technological advancement recently called diffusion tensor imaging that provides very valuable information about neurovascular compression. It also shows us whether or not the root entry zone is involved. The root entry zone and the transition zones are things we're going to be discussing momentarily. This advanced imaging has been demonstrated by computer models to correctly identify cases of primary trigeminal neuralgia in up to 88% of individuals using computer models. This from cephalalgia from a few years ago. The primary factor resulting from this vascular compromise is demyelination, of course, of the primary sensory trigeminal afferents. So it's important, therefore, to utilize these advanced imaging modalities to determine whether or not we have demyelination, and sometimes atrophy as well. The demyelination is actually caused by this neurovascular compression or compromise. We call it a conflict, which produces morphological changes of the trigeminal root, for example. However, studies have shown that only about half of individuals with primary trigeminal neuralgia will actually have morphological changes. Secondary trigeminal neuralgia, of course, is due to things like MS, which is very commonly associated with trigeminal neuralgia, space-occupying lesions, tumors, and sometimes trauma. And individuals who've undergone otherwise uneventful genetic procedures, microvascular decompression, many times scarring results in a residual condition of trigeminal neuralgia. This is an MRI from a patient with left-sided classical trigeminal neuralgia. You can see that there's an arterial loop from the anterior inferior cerebellar artery here. Oops, back up. Back. Am I going too far backwards? Here. And these are the vascular loops right there. Here's an MRI in another patient with a classical left-sided symptomatic trigeminal neuralgia. Fast field echo sequence is the terminology used to differentiate and delineate this from a standard MRI. And this is from compression of the nerve from the meningioma. Both the meningioma and the nerve are seen right here in the circled area. Neurovascular compression, this is from the New England Journal of Medicine recently. An MRI scan shows, again, neurovascular compression by a loop vessel. The white arrows right over here. And the nerve is shown in black here. This is the classic primary trigeminal neuralgia in somebody with neurovascular compression. Now, it's important to differentiate and distinguish what type of trigeminal neuralgia the patient has. Clinically, the types may be indistinguishable on physical examination and based solely upon symptomatology, which is why the MRI scan continues to be the gold standard for differentiating primary from secondary types or idiopathic types for which there is no known cause. And again, never rule out the possibility that somebody who's had an otherwise uneventful surgery might present with scarring related to that surgery from the DuPont Teflon patch, which may result in an ongoing stimulus for symptoms. Now, it's important also that we understand the transition zone between the peripheral and the central myelin. That's an area which is prone to compromise. And the root entry point, or the root entry zone. These are the areas of the trigeminal nerve which are most prone to neurovascular compromise by the superior cerebellar artery, which is the #1 artery implicated in cases of primary trigeminal neuralgia, not the AICA or the PICA. This is a 48-year-old gentleman with a sudden onset of unilateral hearing loss, and the porous trigeminus is visualized. The root entry zone is marked by the arrowhead. And this is the area of interest right here. We call that the transition zone. The transition zone is that zone which is found between the peripheral and the central myelinated portion of the nerve. Again, an area very much prone to neurovascular compromise by the artery. This is a 69-year-old woman with a 2-year history of right-sided trigeminal neuralgia, symptomatic compression of the proximal segment. Again, we use this phenomenon when a steady-state pre-precession that's attendant to the newer MRI scanners. And this shows the superior cerebellar artery with the arrows contacting the trigeminal nerve right over here. And we see that over here. And over here, it's in the proximal segment. Here's another patient, a 62-year-old patient with a 4-year history of right-sided trigeminal neuralgia. And you see again the superior cerebellar artery being implicated in this neurovascular compromise. That is the most common artery implicated, with other arteries including the AICA, the PICA, and sometimes the vertebral-basilar artery system, but they are much less likely to be implicated than the superior cerebellar artery. And arrows indicate the area of compromise here and over here. 67-year-old woman, asymptomatic, yet having vascular compromise. So it's not always the sine qua non that somebody who has anatomical imaging demonstrating that there's contact between the superior cerebellar artery and the nerve, that they're likely to have symptoms. That is the case in primary trigeminal neuralgia most often, but there will be cases in patients who present who have these findings who have absolutely no symptoms at all, as in the present case. And even though that there's compromise and contact there between the nerve and the artery, this patient was asymptomatic. This is a 40-year-old gentleman who did undergo an otherwise uncomplicated microvascular decompression, also known as Jeanette's procedure, several years earlier, who developed scarring around that pledget and around that nerve, who required a repeat surgical procedure. I spend a lot of time in the Caribbean. Recently I've been going down for almost a year now for stem cell therapies, and one of the primary indications for our stem cell use is patients who've had failed genetic procedures. I've taken care of about half a dozen patients so far who we perform CT scan guided trigeminal stem cell infusions, and so far we've had no complications and we've had great success. But some people will develop scarring that is either amenable to a repeat surgery or sometimes one of the procedures that Dr. Nehru's and others are well known to do. So this is a patient who had it. The black arrow indicates the DuPont Teflon pad right there, and the patient developed extensive scarring requiring a repeat surgical intervention. These are two patients with right-sided trigeminal neuralgia, a 72-year-old woman and a 79-year-old woman. And once again, we see that there's compression of the superior cerebellar artery with the trigeminal nerve at the root entry point. So we know that in only about 80 to 90% or maybe 85% of cases we have primary trigeminal neuralgia. The other 15 or perhaps 10% of cases are due to secondary causes. The most common secondary causes, again, are due to things like multiple sclerosis, tumor, trauma, rarely infection. I've seen a couple of patients who've had herpes simplex type 1 primarily of the Gasserian ganglion who've had presentations as such. That's very difficult to see using MRI imaging. The most common compromising or compressing artery, again, is the superior cerebellar artery, followed by the anterior inferior cerebellar artery and the basilar artery, and sometimes the vertebro-basilar artery complex can also be implicated in these cases. Also, never underestimate that there are venous structures which could potentially also be implicated in causing trigeminal neuralgia. The most common are the superior petrosal and the transverse pontine veins. So these can also be due to venous obstruction, although that is much less likely to occur than arterial obstruction. Again, you can have somebody with MS who has what is known as a double crush syndrome, where they have primarily the multiple sclerosis plaques being implicated as causing trigeminal neuralgia, but they can also have arterial compromise of the structure and therefore have a double crush syndrome. It can also be due to tumor, AVM, compression, inflammation, and trauma, which we've already discussed. Sometimes you need a higher resolution magnet, which is not readily available to most of us in common clinical practice. Instead of a 3 Tesla, a 7 Tesla magnet has been developed, which is useful for finding some of these more discrete lesions. Every case of trigeminal neuralgia should be investigated using MRI imaging. But this is very important for determining and differentiating the cause of the condition, because if it's due to a microvascular compromise or a neurovascular compromise, sometimes microvascular decompression remains the technique of choice. Although for the interventional pain physician who is not a neurosurgeon, we obviously have other tools in our armamentarium for rendering patients pain-free, including nerve blocks, the injection of things like absolute alcohol, radiofrequency neurotomy. I've done many of those. And again, more recently, stem cell administration. Now let's switch from trigeminal neuralgia to myofascial pain dysfunction syndrome. Primarily what we're talking about here is a different type of head and neck pain, unrelated right now at the present to the trigeminal nerve. This is typically due to the temporomandibular joint, and there are definitely imaging modalities available to us to determine whether somebody is suffering from this myofascial pain dysfunction syndrome. Among them are arthrography, CT scans, MRI imaging, and scintigraphy. MRI remains the gold standard for making the diagnosis of temporomandibular joint dysfunction. Here's a systematic review of the neuroimaging literature regarding 2 different neuropathic pain conditions, temporomandibular joint dysfunction pain as well as trigeminal neuropathic type of pain, to determine the utility of using imaging studies. Tomorrow I'm going to be discussing blood oxygen level dependent signals when I talk about what's new on the brain, or BOLD, bold. But right now this was a qualitative meta-analysis performed by examining both brain function as well as brain structure. And what did they found? They found that the common pathway for all of these painful conditions was the thalamocortical pathway, as you might expect. However, there are functional and structural changes that we frequently see in the prefrontal cortex as well as the basal ganglia, which suggests, at least in these patients with chronic neuropathic pain in the face, that in addition to the thalamocortical pathway, we also have cognitive modulation and reward processing being implicated in the perpetuation of pain. Let's look exclusively at the TMJ now. Reliability of imaging of the TMJ has been difficult to prove using prospective studies. There are various modalities available. CT scan imaging, again, MRI remains the gold standard for identifying temporomandibular joint dysfunction syndromes. We also have things like ultrasonography. Again, there's no evidence in favor or against the use of ultrasonography, but it's cheap, relatively available to most of us who practice chronic pain, and available in most major institutions. Edema should not be considered unless you're looking at the contralateral side to rule out that this is just a person prone to the development of edema. And osteoarthritis should not be considered to be the diagnosis unless, of course, there are other concomitant findings consistent with that patient having osteoarthritis. Panoramic radiographs are rarely useful. Here's an MRI showing partially displaced discs in the open mouth as well as the closed mouth positioning, and that's important when you're sending a patient for a diagnostic study of the temporomandibular joints. It's important to instruct your radiological technicians that you need both open as well as closed mouth views. Temporomandibular joint disorders, current concepts and controversies. MRI remains, again, the gold standard, just as for trigeminal neuralgia. Classification systems combine clinical and MRI findings to stage the extent of the internal derangement of the condyles and to guide the treatment protocols. And therefore, if someone is being considered a candidate for surgery, it is mandatory to assess that patient using magnetic resonance imaging. Here's a closed mouth and then open mouth view with dislocation and translocation of the temporomandibular joint. Very important to have open and closed mouth views. CT scan imaging may be considered useful for some cases. Cone beam computed tomography, CBCT, has been utilized with some success in cases of ankylosis or where there's osseous surgery being contemplated. But again, it's not the gold standard. MRI remains the gold standard for TMJ. Ultrasonography has been considered useful because of the ease of application, but its effectiveness as a diagnostic method has not been confirmed. Same with scintigraphy. Scintigraphy of the bone has been considered in inflammatory conditions, once again lacking scientific support in the literature for its use. Let's look at other types of neurovascular compression syndromes. I indicated earlier to you that the compression by a vascular structure to a cranial nerve is not unique to the trigeminal. We also see, in addition to cranial nerve 5, 7, 8, and 9 being implicated. They're usually caused by arteries, occasionally caused by veins that directly contact the cisternal portion of the cranial nerve. And again, the transition zone that I mentioned now a few times is that zone between the central and the peripheral myelin, and it's unique to each of these cranial nerves, which is why it's critically important to understand what that transition zone is, where it's located, because if that's where the compromise is, then that's where the application of the therapeutic options is going to be. The transition zone typically, but not exclusively, overlaps with the root entry zone for the majority of these cranial nerve syndromes, except for cranial nerve 8. So trigeminal neuralgia is the more common of these cranial nerve neurovascular compression syndromes, about anywhere from 4 to 20 out of 100,000. The least common is Glossopharyngeal Neuralgia, only 0.5 out of 100,000. I've had 3 or 4 cases, including one very difficult to treat case that I'm managing at the present time. So the transition zone is 4 millimeters for the trigeminal. For cranial nerve 7, it's 2.5 millimeters. For cranial nerve 8, it's 1.1 centimeters. So that's the unique cranial nerve for this transition zone. And the transition zone for the glossopharyngeal is 1.5. Again, you can take a look at this graphic. This tells you where the area of implication is or compromise is for these respective nerves. Here's normal anatomy for trigeminal nerve, cranial nerve 5. We've already gone over this in great detail, showing the motor root of cranial nerve, the short arrow in C, and then the sensory nerve, the sensory branch of the trigeminal nerve for cranial nerve 5. Hemifacial spasms, cranial nerve 7 involvement, the facial nerve. This shows you the pica or the posterior inferior cerebellar artery contacting the nerve over here, leading to hemifacial spasms in a 54-year-old gentleman who had to undergo surgical restoration of that nerve. Here's right hemifacial spasms by the AICA in a 60-year-old gentleman, showing once again contact, secondary contact and primary contact through the pica and the AICA, and once again the patient was improved after surgery. Surgery did help to resolve the symptoms. Neurovascular compression in a 70-year-old gentleman with tinnitus and vertigo over here. So we're talking about cranial nerve number 8 over here, and you can see the areas of compromise here of both the cochlear nerve and the vestibular nerve for this individual having tinnitus and vertigo, also underwent uneventful surgery. Glossopharyngeal neuralgia is relatively uncommon, 0.5 out of 100,000 individuals, a very short transition zone of less than 2 millimeters. Here's glossopharyngeal neuralgia by tortuous vertebral artery in a 64-year-old gentleman, and you see T2 weighted images of the vertebral artery being seen with the short arrows over here, compromising the glossopharyngeal nerve. Once again, this individual required a surgical intervention to relieve him of his symptoms. Here's left glossopharyngeal neuralgia caused by pica, the posterior inferior cerebellar artery, in an 80-year-old person who was otherwise disease and symptom-free. Once again, the individual underwent an uneventful surgery to relieve him of these symptoms. Geniculate neuralgia, a very uncommon condition as well, and you have to, again, utilize MRI imaging to determine and render the patient having a diagnosis. Most important investigation is assessing it as a fine-cut MRI of the cerebellopontine angle. Sometimes CT scan imaging may be useful, but again, MRI remains the gold standard. Here's a 39-year-old gentleman with a history of left deep ear pain for the ear canal that lasted several years. He had geniculate neuralgia, and there was a tortuous vertebral artery pica complex with the pica loop impinging on the vestibulocochlear nerve. These are the actual images from this individual, T2 and T1 weighted images showing that compression of the glossopharyngeal and the facial nerves in this individual. Intermediate nerve neuralgia also is another condition which may be cured by the use of microvascular decompression surgery, but it's very difficult to see these nerves, and again, the nerve is extremely small, not visible even by high quality MRI scanning. Therefore, preoperative neuroimaging studies cannot clearly display the neurovascular conflicts occurring in the intermediate nerve. Here's a 55-year-old woman with a 10-year history of hemifacial spasm. That's actually due to compromise of cranial nerve 7. MRI revealed the presence of the vessels around the facial nerve root. This individual also underwent surgery to relieve her of her condition. Occipital neuralgia, one of the last things I'll discuss. Very interesting condition. Obviously, it must be distinguished from primary and secondary headache disorders. Can be referred pain from the atlanto-occipital, the atlantoaxial, as well as the upper cervical zygapophyseal or facet joints. Diagnostic ultrasonography, very useful for this condition. And in fact, it's the only modality which can render a clear-cut diagnosis in the vast majority of cases, because you can see the greater occipital nerve all the way from its origin at C2 until it becomes subcutaneous at the trapezius, aponeurosis. The normal diameter of the nerve is 2.0 millimeters, and individuals who have some type of compressive neuropathy can see swelling and edema of the nerve up to double its size. So here's actually GON at 4.1 millimeters plus or minus 2.6. This shows the entrapment between the semispinalis capitis muscle and other muscular structures in the suboccipital region. Here's the interior oblique muscle here, and here's the semispinalis capitis, and this shows entrapment in the suboccipital muscles. But the greater occipital and the lesser occipital nerves, and the greater auricular nerve, they can all be compressed not just by muscular structures, but also by vascular structures as well. And so you can see impingement by arterial vessels here at C1, C2 level between the inferior oblique and the semispinalis capitis muscles. You can also have venous aneurysms and malformation here. You see impingement of venous structures on the greater occipital nerve between the inferior oblique muscle and the semispinalis capitis muscle. Here's a space-occupying cyst, which was causing compression of the greater occipital nerve, again, in close proximity to the semispinalis capitis muscle and the inferior oblique muscle as well. Finally, lesions at the level of the C2 dorsal ganglion can mimic these conditions and can be ruled out by the use of ultrasonography. And so ultrasonography is very useful for managing these types of headache pain related to compression, irritation, or some derangement of the occipital nerves. So in summary and in conclusions, MRI is the best imaging modality for studying trigeminal neuralgia and for determining whether the condition is primary or secondary. The 3.0 Tesla is the best modality for viewing neurovascular compression. Lesser degrees of resolution may be essential for helping to determine when tumors are involved or multiple sclerosis is involved. Diffusion tensor imaging, DTI, is best to evaluate root entry zone. Root entry zone is a very important concept in all of these cranial nerve dysfunctions. Myofascial pain dysfunction syndrome is best evaluated again using the MRI. MRI is the gold standard for temporomandibular joint dysfunction, for example. These transition zones, very important to understand and conceptualize them. They're relatively short for most of the cranial nerves. For 5, 7, and 9, the transition zone for cranial nerve 8 is actually 11 millimeters. It's the longest of these cranial nerves known to undergo neurovascular compression. Geniculate neuralgia best assessed with MRI of the cerebellopontine angle. Ultrasound, in my opinion, is the best for diagnosing occipital neuralgia conditions. And I'm not going to talk about optic neuritis. I actually, to save time, I deleted that entire section of the talk. CT scan has limited usefulness in imaging for the painful head and neck conditions, with some exceptions for the TMJ and some exceptions for cervical facet joints. I thank you for your time and attention. I hope I stayed on time so that I don't disrupt the other speakers, and happy to answer questions at the termination of this session. Thank you very much.